Okay, we will now be starting the panel discussion on spine. So hopefully we can take all the questions that I'm sure everyone has on that great lecture and we can segue them in for everyone to answer. I will go ahead and share some of the survey results. So we had everyone try to fill out that survey so we can kind of understand where the biologic environment is right now. And the results were pretty interesting. So we had a total of 79 people that completed the survey. And I'll read off a couple of them for you. You will obviously get a hard printout of it, so no worries there. But here's some of the interesting things. So approximately 42% of the people that filled out the survey have been using PRP for more than 5 years. So that's pretty interesting. A lot of people have been using it for a while. 47% have had no experience with bone marrow concentrate, and 61% had no experience with lipoaspirate. So it seems that a lot of people have been using PRP for a while, and now maybe the transition will start happening with bone marrow concentrate and lipoaspirate as well. Also interesting, 63% of providers are not using supplements to support their PRP currently. There have been discussions about that throughout the week, the weekend, and hopefully maybe it'll expand into that in the future. 75% are not using amniotic tissue at this time. When talked about the locations of where PRP and bone marrow concentrate have been used, they pretty much have been used widely throughout the body in most peripheral joints, with the knee being the most common and the spine being the least applied area. But also interestingly, prolotherapy has been used in 42% of providers who are using that in the spine. So a little bit less of a percentage have been using PRP, and a little bit larger percentage have been using prolotherapy in the spine. So possibly there could be some transition there as well. Now, although there's only 79 people that responded to the survey, I think this kind of can help provide a little bit of the environment of how biologics are being applied, and hopefully in the future we can expand these numbers and really kind of get a grasp on how everyone is applying it. So very exciting stuff. Also, another quick reminder, the CME post-test will be going on after the lectures. We'll be discussing the cases and answers and everything, so make sure you stick around for that. I want to make sure you pass all that and get the 11.5 credits this year. Okay? So now we are going to start the panel. We have a very, very expert panel on spine and regenerative injection treatments of the spine. I will list them off here for us. From the Ortho Healing Center in Santa Monica, California, we have two participants. We have Dr. Mary Ambach and Dr. Daniel Alfiero. From Hospital Special Surgery in New York, we have Dr. Lutz. Coming back to the stage, we have Dr. Navani. We also have Dr. Michael Robbins from Yale University and Yale Pain Clinic. Dr. Wesley, who spoke yesterday from the Sierra Stem Cell Institute in Reno, Nevada. And we also have Dr. Carlos Garcia from Premier Pain Care in Denton, Texas. The moderator will be Dr. Desai, who just recently spoke. Enjoy.
Well, thank you for being here again, and this esteemed panel. I'm honored to be here to help moderate the discussion. And so what we'd like to, the format we'd like to use is probably 15-20 minutes of some case presentations and how our esteemed colleagues here would handle those cases, and then we'll open up the floor for discussion. So we look at these things, we talked about these before: herniated disc, facet, spondylolysis, post-laminectomy syndrome, spinal stenosis, sacroiliac joint pain, and whiplash. And we're going to kind of go over these cases. And questions to the panel that I'd like to ask is your approach, diagnostics, steroid use, post-procedural follow-up, and retreatment. So case one, talking about low back pain, fairly simple case, a herniated disc, no concomitant pathology with radicular symptoms. And so we'll just go down the line and talk about how one might approach this case, especially with regenerative medicine available. Yeah.
Given that the patient failed conservative treatments, physical therapy modalities, and medications, we go through the usual standard injection treatments for radiculopathy. I would start with your regular epidural steroid injection, and if they do get good response with the epidural injection and they want to stay on that course, then I may repeat it a second and a third one. We would consider the regenerative injection therapy through a transforaminal or a translaminar approach using PRP lysate. If they're interested to try other alternative modalities, I may even try a dextrose epidural the same way as Dr. Smigel in Hawaii uses dextrose epidural to calm down radiculopathy.
And you'll do a 5%?
Yes,
concentration?
D5W, exactly.
Yeah, okay.
Adding to Annette's comments, I would just say another option other than the lysate epidural and the 5% dextrose, you can also consider ozone therapy. And a similar technique, whether it's caudal or translaminar or transforaminal, and basically with or without steroid, chase the injection with approximately 9 cc's of ozone and reevaluate in 1 month. If the patient's doing well and holding symptoms, then no further treatment. If the patient's pain has recurred to some degree, then I would repeat it, typically a series of 3 spaced 4 weeks apart. But again, lysate would be the #1 choice from a regenerative standpoint.
Yeah, 1 or 2 transforaminals, they don't get better, and it's an extruded disc. There's a reason why it's not getting better with a transforaminal. It's usually a hard disc. It's usually in the axilla of the nerve. So it's not just inflammatory, it's mechanical. So I have no problem with recommending a microdiscectomy in those patients. The results are really good. This is not a, fusion surgery. And so all the other stuff, I might start trying an epidural with PRP, if the data is solid. I think, it's all about data. But, transforaminal has been around for 20 years. They've been, really working well for most patients. And so the other stuff I'm interested in, but I'd like to see more data.
I think that's a great way to start off the patient, although at this time, I would also start thinking about modulating therapies to see if we can go to the source and address the problem. Given that the radicular symptoms and low back pain are indeed coming from the herniated disc, I'd like to know if the disc herniation is contained or is an extrusion. If the symptoms correlate well in terms of clinical symptoms and imaging findings, and if I can narrow it down. The next thing I'd like to know if the disc is degenerated or if it's just a herniated disc with a good disc height and hydration. Because at this point, depending on the response of the epidural injections and the longevity of it, I'm starting to think about intradiscal therapies. So that would be my take on it.
I agree with the other panelists here in their approach, but one of the other things I look at as well is first basic, keep it basic, some physical therapy, back extension exercises, McKenzie exercises. But I'd also like to know a little bit more about what we're dealing with, like Anu had just mentioned. Take a look at the MRI, see what the Furman grading is of the disc. Does it include a herniated disc with or without an annular tear? And does it include modic changes? Because I think that's a big difference in what we would do to address this. And that's going to direct the pathway initially.
I think been a lot of good advice given. I wouldn't really offer anything significantly different. I think the imaging is very important to quantify what's there and what could potentially be going on with the patient. With regards to surgery at this point, I'm assuming we're about 6 months out and we've tried most conservative care. If the patient's in really severe unrelenting pain and there's significant neurological compression associated with a deficit, I still think a microdiscectomy is probably the best evidence for getting them feeling better. Now, if their symptoms are fairly well tolerated and they're still functional and they've got time, then there are other options. And I think certainly considering an intradiscal regenerative procedure is reasonable. I've had some success doing sort of a quirky little treatment of intradiscal ozone, and I have a lot of literature if you want to look at that. And it's helped me save these patients. I typically get 2 to 3 years of relief. But again, the imaging is critical because if there's a lot of bony stenosis, you're going to waste your time.
Since this is a regenerative conference, I'm going to concentrate on what we do in terms of the regenerative options. First of all, not all discs are created equal, so a lot of times it's patients with radicular symptoms, presuming that we're talking about radiculitis, not radiculopathy. So that's a big difference in the management. So according to the regenerative capability of the patient, we have a classification. We look at different options. So we had to assign the patient into a risk category in terms of correlation between the patient's ability to regenerate and what we do. So first thing is that a lot of times we use nerve stimulator to make sure that very frequently with a herniated disc, whether it's contained or not, you see two different nerve roots irritated at the same time. So our approach, if we're trying to avoid steroids, which by the way, we still use them in our practice, our default solution is IGF-1 and D5, and occasionally ozone. I've been using IGF-1 like holy water for the last 2 years, and I'll tell you my experience is phenomenal. If that doesn't work, then we offer the patient a PRP. Usually, anything that doesn't respond to steroid, basically there's some degree of nerve damage, okay? If the PRP or a selective nerve root injection does not work, then we go straight to discography. Now, depending on the location of the herniation, we're very aggressive. Sometimes we go straight. If I can't get the extrusion absorbed by the PRP, which by the way, PRP upregulates collagenases, agrokinases, and all that. There's a great literature on that. Okay, that's how it works when you're dealing with extrusion. Then we might go to a minimally invasive percutaneous discectomy, and all my discectomies are treated at the same time with bone marrow, according to the degree of degeneration. You know, if it's a class 1 disc, I might do PRP, but usually we follow bone marrow, and I've done probably, 200 discectomies for the last 5 years with 0 recurrence using that technique.
Thank you for that. The discussion kind of went to that point is, these are disease-modifying therapies. So we're actually able to change the course of the patient's disease. It's no longer, the cortisone until things don't work anymore and then a surgery. So it's very interesting to see where you might jump off for your patients into that regenerative realm. So case 2, we're going to go low back pain, spondylolisthesis, no neural impingement. And so now we're talking about the instability and low back pain. We could start. Carlos, do you want to start?
So basically, it's like most of us, you start with the diagnostic injections. We use, I don't do median branch blocks anymore because it really doesn't tell me that much about it. It's very non-specific. So if I'm interested in a specific pain generator, I might go with a very diluted local straight to the facet joints right away. Again, I follow immediately with IGF-1, it's very benign. And I walk around the patients and make sure, of course, we got to presume that we optimize the patient, treat it, evaluate the causes. And that's our first entry-level intervention. It's diagnostic and pseudo-therapeutic. And then we follow the path of, PRP, if that doesn't work, but not only in the capsules, but multifidi and ligaments.
From an interventional pain standpoint, I think most of these patients have posterior column pain, usually involving the facets. There can be some discogenic component as well because the disc's usually pretty degenerated. I've had the traditional approach would be, if you get confirmatory blocks, to consider ablating the associated medial branches or dorsal rami and anesthetize the joint. But like many of you, I've become less enamored with that approach over time. I think it's not very repeatable all the time, and I'm really concerned about core weakness and potential instability. And I've had good luck treating these people with regenerative means. I've done PRP, but in my hands, I don't get much more than about 6 months relief with our current PRP formulation. I've more recently switched to a stem cell PRP combination treatment, and results have become much better and a little bit more durable. I've only got a few patients out past 6 months, but at least I'm not seeing recurrent pain, so I'm happy about that.
As far as this is concerned, I don't have as much experience with PRP or bone marrow for patients with spondylolisthesis as my colleagues may have here, but first of all, patients with this spondylolisthesis, with or without neural impingement, is it a sliding spondylolisthesis or is it relatively stable? And then pretty much going into looking at stabilization techniques, strengthening back muscles or whatnot for that. But I haven't had the experience of doing the regenerative for cases such as this. Usually, if they fail all the above and they still continue to have axial back pain, and they fail all the blocks and the injections that we've done, my patients have typically gone to see a surgeon.
So given a case of low back pain with spondylolisthesis, I think the number one thing that comes to my mind is if they have stable or unstable spondylolisthesis. So flexion extension films will be the first thing I'll get, in addition to their history in terms of how their symptoms change with different positions. If it's grade 2 or more, I'll get a surgeon involved right away. And get a blessing first. If not, if it's a stable spondylolisthesis with pain without significant neurogenic claudication that happens with posture changes, then I'll try to see if there are interventional procedures that I can do to give patient the comfort he or she needs to get into physical rehab. Because I do feel that strengthening of those posterior muscles and the ligaments is key factor in keeping the spine stable. We have sometimes success with intradiscal procedures as well as facet joint related procedures, be it medial branch blocks or radiofrequency ablations, or even intra-articular PRP or BMAC type of injections. We have had great success with prolotherapy for the posterior longitudinal ligament and posterior muscles. So I would get that person to our prolotherapist. We have an excellent one in our practice who then will work closely with the physical rehabilitation expert who we have and engage the patient in strengthening exercise program.
You know, this is an interesting patient because it's a different subset of disc disease. And you know, in theory, they all have microinstability, and we've tried to do intradiscal PRP on, you know, more, and I assume it's a degenerative spondylo where the pars is intact, there's no congenital isthmic spondylolisthesis. And so in a degenerative spondylo, we tried doing intradiscal PRP, and you can pump that disc up and get it almost this listhesis corrected back to normal if you put enough fluid in. It's just that 6 weeks later, the PRP gets hydrolyzed, and we've re-imaged them to see if there's any sustained improvement, and there isn't. So I think coming up with a formulation that might give sustained improvement would be really helpful because you're going to get indirect decompression of the spinal canal, and you're going to correct the listhesis through an intradiscal procedure, which is a lot better than a fusion. With that said, if you can catch them early, you know, what we do is if there are, you know, a few millimeters of listhesis, you know, we do standing x-rays on everybody, and usually they have a small fissure, and we will do PRP earlier rather than later and do the PRP into the disc and into the joints, like a 360 regenerative procedure, and those patients are responding. And so it's a different subset of patients. I don't know if BMAC will be better. I don't know if a super concentrated PRP will be better, but right now we're doing 10x on everybody. And so we'll see. You know, it would be nice to study this subset.
So at this point, I'd want to know a couple more pieces of information, such as, like Dr. Lutz was saying, whether or not there are associated pars defects that would change my treatment plan as far as BMAC versus PRP. I'd also want to make sure that the spondylolisthesis was the pain generator. Lots of times on these patients, there's coinciding MRI findings like degenerative disc and disc bulges, and I'd want to make sure that it was the facets and the spondylolisthesis. So I'd probably do some form of facet block, whether it's a median branch block or an intra-articular low-dose cortisone with Tramiel or something like that, so that way it allows the patient to get a few days worth of relief to tell me that indeed their pain was significantly better, even though I'm not correcting the biomechanical component. A comment about the instability x-rays, I find that there's a high false negative with these patients. A lot of their psoas are hypertonic, a lot of muscle spasms. So even with flexion extension views, it's as if there's just, the testing isn't as specific to pick up on subtle movements. And if patients tell me they go to a chiropractor and they get significant relief, or they go out where their back locks up on them, then that's a high likelihood that there is some component of microinstability, even though macroinstability is not being picked up on imaging. Once I would confirm that it is the facet, the degenerative facet joints or the pars as the pain generator, then I would start with PRP, assuming they've failed physical therapy, conservative treatment, bracing, modification of activities. And so I would start with a PRP if there are no pars fractures. If the patient is extremely flared up, I use a red blood cell-free system, and that way I'm not additionally adding inflammation to their already severe pain. If the pain is more tolerable and they're not that flared up, there's no effusions in the facet joints, then I might use more of a red blood cell based PRP system. Typically, I do a series of 3, 1 month apart. I put 1 to 2 cc's in the lumbar facets and approximately 1 to 2 cc's in each of the spinal segment central ligaments, including the interspinous and supraspinous. I do the ligaments under ultrasound guidance and the facets and pars under X-ray guidance. If there is a pars defect, I would start with BMAC to improve the likelihood of any healing or improvement in that bony defect.
So in addition to what Dr. Afiero said, we do go for a platelet-rich plasma injection into the facet joints. We inject about 1 cc into the joint, pepper about 0.5 to 1 cc in the capsule, and then we inject 1 cc in the interspinous ligaments. If they had previous radiofrequency ablation before, we do find some atrophy into their multifidi muscles, erectors. We also add some either fibrin or platelet-rich plasma into those muscles. And if they do have an associated pars defect, and if their facet degeneration is more advanced, then we may opt to start with the bone marrow concentrate. And if we do that, we do follow it up with a platelet-rich plasma injection 4 to 6 weeks later.
Okay, great. And then just one thing to add is, with the iliolumbar ligaments, something to concentrate on as well, especially if it's at the L5S1 level. We've seen a lot of benefit with treating those just because of the stretch that's occurring there. Case 3, spinal stenosis, obviously chronic low back pain and neurogenic claudication. Is there any role for regenerative medicine in this situation?
Spinal stenosis is tough, unfortunately, because you do have multi-factorial etiology for the pain. They not only have degenerative disc, they have facet arthropathy, they've got thickened ligaments, they've got instability. So it's really a matter of what your history and physical exam will dictate, what is their primary pain generator. If it's a disc, then we chase the disc first. We use bone marrow concentrate in our intradiscal injections. If it's facet, we use PRP or bone marrow concentrate. If it's radiculopathy, then we need to quiet down the nerve and do some regenerative injections, at least to help with remyelination and nerve healing. But you can only do so much with the regenerative injections. There is a role for surgery in some of these cases. It all depends on what the patient's goal is, where they are in their treatments, and their neurologic exam.
I agree with Dr. Ambach. This is a challenging one, especially when there's bony overgrowth of the facet joint or osteophytes. I think they have a better prognosis with regenerative treatment if the disc is involved, and that way the disc can be treated intradiscally. But I tell patients that the prognosis is fair for regenerative treatments unless they do have disc pathology that can be treated, because bony overgrowth is extremely challenging, and I find that the PRP epidurals don't last as long as patients would like them to in order to justify ongoing PRP epidurals in these situations.
So, with stenosis, a third of patients stay the same, a third of patients get better over time, and a third get worse. That's just general rule. And we use epidurals till the cows come home. If they get less than 6 weeks relief, I don't keep doing them, but if they get 6 to 12 months relief, we just keep repeating them and combine it with exercise. If that duration gets less, then we look at surgery, and the best surgery for this condition, I think, is a microdecompression. And if they have disc that's savable, then you can, after the microdecompression, then you can go to treat the disc. But I haven't done any epidurals with PRP for stenosis, and I'm just waiting for good data.
So I guess one of the key questions here is, it is mild stenosis versus severe stenosis, because that changes the paradigm of treatment. Given that this patient has neurogenic claudication, that sounds pretty significant. So in terms of intradiscal therapies, as a general practice, we don't do it for patients with severe stenosis. And with regards to other intra-spinal biologics, I agree with the panelists. The epidurals, no matter what injectate you use, don't last very long, given the mechanical compressive forces there. If it's severe spinal stenosis, patients do well with spinal decompression, and I think these are that population that will do well with surgery. And I agree with Dr. Lutz. Some of these patients will benefit with intradiscal biologics and even other biologics around in the spine, including facets, if there is a facetogenic pain associated with it, even post-surgery. So I think it's important that we look at the whole picture and see what exactly the cause of spinal stenosis is and the severity of it in determining a treatment paradigm.
I'll keep it simple because I agree with the rest of the panelists on this, because it depends on how much involvement there is of the posterior elements and are they candidates for regenerative medicine. But the neurogenic claudication is the key here. And in my experience, they would go on to either have surgery, but there are interspinous devices that can be placed depending on the degree of stenosis that's minimally invasive that might help the patient rather than having a full, complete laminectomy as well.
I don't have too much more to add. I think that the type of stenosis is important. I think if it's bony stenosis, I really think the data shows that a surgical decompression, although it's not a perfect procedure, it still has probably durability of about 2-3 years. I think the reoperation rate's about 20% over 5 years. It's interesting though, you know, with my experience, I don't know how many of you did the mild procedure that kind of came and went. I was impressed to how just a little bit more room in there can make a big difference in these patients. So maybe if the mild procedure becomes available again, that's the way we can make a little bit more room by trimming off this ligament and flavum. Whether PRP can be an adequate substitute for epidural steroid injections is still unknown. The latest data on epidural steroid injections for spinal stenosis, as you know, is very poor. And whether or not something can be done with a disc is important too. Someone may have some ligamentous and facet hypertrophy, but if that disc can be brought back, perhaps by regenerative injections or by other means, perhaps that's another approach that can avoid surgery.
That's kind of interesting. It's almost like, how do you treat migraine? So I agree with everybody here. You know, basically, you follow the trend. You know, it's like if they're neurologically they're intact, you have choices. So epidural steroids useless, not useless, you know, but very limited in terms of value. Recently, we've been experimenting with D5, the so-called sweet cuddles, with ozone and IGF-1, fantastic. But the second that the patient starts to turn south and becomes more weak, you got to explain to the patients that a decompression does not reverse neurological changes. So as long as the patient understands that they're asking for palliative treatments, it's okay to continue a non-operative care. As of the mild, it's going to be resurrected pretty soon. If you guys don't know what it is, basically it's a minimal invasive procedure mainly geared towards the compression of the hypertrophy ligament. It doesn't work when the stenosis is secondary to osteophytes. Okay, and it's a phenomenal procedure with minimal instability, and that could be a great adjunct for regenerative interventions. Once you decompress them, as we all know, they have facet joints, they have radicular symptoms from lateral recess stenosis. So that is going to be one procedure that will be a great acquisition for our minimally invasive treatment of these patients.
I want to move to, instead of going through more cases, I'd like to open up the floor for questions. And if we have time, we can get back to the cases. But
yeah, this wasn't a question. I would just add to what Carlos was saying. What is present now is the endoscopic procedures. And sometimes, you know, in some cases they might cover that. And it's actually a visualization of the area as opposed to just the mild procedure. And you can do also bony decompressions. There is a study out there Gabe Jasper did a study, I think, on Medicare patients with spinal stenosis and endoscopic surgery. So that's minimally invasive, which goes along with regenerative medicine in that it preserves the multifidus and other areas, but you're getting rid of the bony overgrowth. The other thing is, like you said, you can do D5W till the cows come home. Steroids 3 times a year, 4 times max. You know, you can do D5W with ozone and get someone very comfortable, maybe see them every 6 weeks or 2 months and carry them on. Don't forget, some of these people are 80 years old, so surgery isn't always an option for them as well. So you need other tools in the toolbox.
How does PRP work? This is for Dr. Lutz. How does PRP work in the disc? Is there a mechanism that we know that results in healing?
You know, if you look at all the preclinical studies, there's really good data on both in vitro and in vivo that PRP upregulates nucleus pulposus cells to increase collagen synthesis. So that's one possibility. The other possibility is that we know there's a downregulation of pro-inflammatory cytokines with PRP. And then, you know, you wonder about the sealant effect of what you're injecting with the fibrinogen, creating that sealant. And if you can seal the disc and create some scaffold with the fibrin, you may reduce the leakage of nuclear contents into the outer annulus so that there's not that chemical sensitization. So I think the disc may be one of the best places for PRP, other than tendon. And so, you know, I think we don't know what the upper limits of the concentration that's needed in everybody, but I think there's good data to support it, both preclinical, and now we have some good clinical data that we'd like to expand on.
I'll ask the same question I asked yesterday to the panel. Is there any studies or data about the toxic effect of contrast media on PRP or any on MSC? Also, another question to the panel. Dr. Lutz seemed presented his results on the efficacy of PRP in annular tear. Some others use it for herniated disc. So what's the mechanism of action of any regenerative therapy in herniated disc and not in degenerative disc disease?
So that first question, Andrew, if you would take that and then we can...
You know, if you do this job long enough, you really get humbled. And I can remember back at the beginnings of ISIS, and we thought we were doing such great things with these discograms. And then Carrigy in 2009 scared the daylights out of all of us. But, you know, I never was too convinced that it was a disc puncture, although it could have been. But now there's some really good data on what these contrast agents and local anesthetics are doing. Their paper came out last year out of the NIH. You can just Google bovine disc contrast toxicity. It's a beautiful paper. And it turns out that so what they did is it was a bovine study. They cultured annular cells, nuclear cells, and they just put them in different concentrations of various contrast agents and local anesthetics. And it's remarkable those cells die off, and dramatically so, especially at higher concentrations of both those agents. So it makes me think that these results we're getting after discography are having to overcome that hurdle. So it's made me rethink about if I do a discogram, how am I doing it and why am I doing it, and do I need to do it? And is doing a discogram more than just treating a disc that looks bad on imaging and not worrying about it? I don't know. These are questions that I'm still sorting out. And as far as the intradiscal stem cell procedures go, I avoid any contrast agents, any local anesthetic in the disc. I'll numb them up, obviously, as we carry out the procedure, and also antibiotics, because antibiotics have been shown to be potentially toxic to these fragile cells. I'll give them systemic antibiotics, and of course, rigorous attention to aseptic protocol throughout these procedures is critical. But that's how it's changed my thinking. I don't know if any others would like to add to that.
Yep. Dr. Garcia mentioned the use of dextrose in your practice. So can you elaborate more on the role of dextrose in various conditions? And for the rest of the panel, would you consider dextrose as some sort of chemical prolotherapy? And how exactly do you think how it works? Thank you.
Well, if I know the answer to that question, I wouldn't be here. Anyway, so the use of dextrose, of course, everybody knows that evolved from the prolo world. And there's a Dr. Lifcock from New Zealand, and he popularized the use of dextrose for hydrodissections of nerve, and it has to do with the influence of dextrose and respiratory cell function. There's all kinds of different theories about why it works. It upregulates, like everybody knows, stem cells. It does work better with IGF-1 because it promotes the anti-inflammatory effect, even though at low concentrations it's not proliferant. But nobody knows exactly how it works. What we do know, it's like it works very well and it's devoid of side effects, considering, your skills. If your skills are well, then so you don't get, bumps in the blood pressure, the blood sugar, you don't have issues with bone reabsorption, and it can be repeated very frequently. I have patients that I've done both epidurals and dextrose, and they like the dextrose better, period. Just anecdotal, Dr. Reeves from University of Kansas published 2 papers now on caudal D5 with excellent results. So that's, the jury's still out, but it's better, I believe, than repeating steroid injections with questionable benefits.
Over here, Ro. In MSK medicine, PRP has evolved beginning with elbow tendinopathy and now with knee OA. And after this meeting, we have some fairly clear understanding of which type of PRP formulations may help in those. And to me, spine is a great frontier with a tremendous need, and we have a lot of work to do, and I commend the speakers for doing the research. Is there any early consensus on any specific PRP formulation with leukocytes and red cells in any particular area in the spine or perhaps in the disc, since that's the area early on, or at least to get the dialogue going and what we need to do further and better understand what type of PRP? Maybe Dr. Lutz could start.
I think going forward, what's nice about this regenerative medicine stuff is that it's really disrupting the traditional pharma model of bringing products out, and you can kind of try it and see what you get, and I think the issue is safety. I think it's a very safe procedure, even though it hurts a lot. But I think we're backing into what may be the right formula just by observing our results. And I think if we can kind of observe our results and see it and maybe quantify it, we're going to be getting some good information. But what I've seen so far is I do think the disc is going to require higher concentrations, and there's some preclinical data to support that. If you look at, there's a great article, it's on our website, Japanese study of a rabbit injury model, and they used a 30x platelet lysate, and at 30x they had regenerative changes. So I don't know what the upper limit is, but I think that some of the bedside point of care kits, we're just trying to maximize what they can do, and going from a 60 to a 3 will get you to 10x. I think if you go 120 to 3, it might get you even higher. So we're just, basically fooling around with it and just trying to be critical of what we're seeing. And I think the other component for the disc is the fibrinogen component, and I think that if there was ways to quantify that and maximize that to seal the disc in a better way, in a more sustained way, I think that would have value. So I think there's, obviously a lot of room for improvement, but first out of box seems to work moderately well. And I think, that's the take-home message.
One question from the...
I'd just like to add a little to that from epidural standpoint. So there are studies, at least one that comes to my mind now, where Schwann cells. So we understand that the PRP has effect on the epidural space and the nerves by remyelination of Schwann cells. There was a study, and I'm happy to forward it to anybody who's interested in it, where rat Schwann cells were studied in different concentrations of PRP, starting at 2.5, 5, 10, 20, and 40%. And they found that the remyelination really occurred between 2.5 to 20. And it's a pretty broad range, but I think more studies are needed to really quantify exactly the percentage, but at least we know that range worked. So there is preliminary data coming out both for interdiscal and epidural, and I think we need to do more work in this field to specify what exactly that number would be in the future.
One more question from the live stream to the panel. Are cancer patients with non-cancer spine pain eligible for treatment?
Go ahead.
Absolutely. Even though there's some recent reports about systemic effects of PRP, it's not an issue really. Unless you have a myeloma that is directly affecting the level that you have, but it's that's very infrequent. But that I'm concerned with or aware of, there's no contraindication.
I would want to speak with the oncologist a bit and see what the situation with the cancer is. I think a bloodborne hematological cancer, you'd have to be a little bit careful. You may be collecting those cells in your preparations, and that could be problematic. But I think if someone is stable, they're out of treatment, their disease is in remission, then I think it's okay to proceed.
I'm in agreement with Dr. Wesley. Same thing, if they're in treatment, they don't have hematologous spread, they've been out of treatment for at least a year, they may be a good candidate for regenerative medicine.
I would agree to that with regards to the type of cancer and hematogenous spread. The origin and the spread is important. Also, same applies for infection. One needs to be extremely careful as to active versus chronic versus remission of infection and the spread of infection therefrom. I think the key point I think everybody should really take home is that these are newer procedures. We are still finding out facts about it. We don't know a lot about it still, and we have to be extremely cautious in how we approach these patients. I think we have to take all safety precautions before we tread forward with this.
I agree. I think the systemic effects of injecting 1 or 2 cc's intradiscally, are probably very negligible. But with that said, I had over the past 6 months, I had 2 patients come in with sarcomas in their iliac crest, and I was just wondering if I had done a bone marrow on that patient from that area, and they came back with a sarcoma, how would that be looked at? So it was just a freak thing, and none of the patients had any procedures, but it was just big gaping holes in their iliac crest. And so I think that it was an interesting phenomenon that made me think about making sure I image the iliac crest before I tap into it.
So Dr. Lutz brings up a good point where, because we're doing experimental procedures, we have to be careful where, even though the likelihood of what we do has any significant impact on the underlying cancer, if there's an underlying cancer, as far as a liability standpoint, it can be looked upon where, because it is experimental, could have it had an impact on it. We like to be a little bit conservative and clear it with the oncologist. Lots of times the oncologists don't really know much about what we're doing, and so we'll send them articles on different growth factors that may transiently increase and have some temporary negative role if there is underlying tumor activity. And we do like to see at least 3 years of remission. We do not typically inject patients who actively are receiving treatment for cancer.
So in addition to what Dr. Alfiero said, most of the oncologists that we do get involved do not have a problem after we explain to them what we're doing. But in all cases, even if it's not an active cancer, we do get the oncologists involved.
Everybody please give a big hand to the panelists. Thank you for sharing that knowledge.